here's what the design looked like. Tier 1. Tier 1 was universally embraced by everyone because it's a real feel-good thing. There were no deductibles, no copays for the ambulatory services related to the 5 big chronics plus depression. So all the chief medical officers agreed, if certain labs are done, certain diagnostics are done, certain generic drugs are made available, and these folks have essentially a free ticket to primary care, we should keep them in control and reduce hospital days and ED visits, right? So that was the free care. Everybody liked that. Each one of these conditions had its own evidence-based protocol. We thought about making only 4 primary care visits for each one of these, but we thought, well, why would we do that? So all primary care was included. So, you know, someone fills out an HRA, it turns out they have diabetes. That's the bad news. The good news in this product, you get a bunch of free care. When claims come into the shop and we get our first diagnosis of one of these conditions, they instantly convert to this benefit design. That's not easy to do. The system setup on that is very challenging. Let's go to Tier 2. Tier 2 is what I would call the usual stuff. Now we did put wellness benefits and preventive services in Tier 2, which is a kind of an 80% benefit. We thought about putting it in Tier 1. You can do that. We couldn't get agreement in the group about what really works in wellness and prevention. It's interesting. We got agreement on the Tier 3, but we couldn't get agreement here. So as a result, we've simply put those services in the Tier 2, but some employers believe this is a better value in Tier 1, and they can do that. That's an option, right? Makes sense? This is things like screenings, wellness benefits, the usual stuff. So everything else that's not in Tier 1 or Tier 3 falls into Tier 2, and Tier 2 is paid at an 80% benefit with a modest deductible. I'll show you that in a minute. Now, Tier 3. This is what, oh boy, see, it doesn't even want to go to Tier 3. It's so controversial. Did I go too far here? Oh, wow, okay. I did something bad here. Okay, here we go. Tier 3. Tier 3 is double the deductible and double the coinsurance in Tier 2 for the following services. Upper endos, all elective imaging, all emergency room visits, right? Hysterectomies, CABG and PTCA and stents, all spine surgery, and a lot of orthopedic work. We needed, in order to get the 10% reduction off a reference PPO product, I'll show you that in a minute, we had to find enough services in Tier 3 to make it meaningful. And if you look at those services, when we ran the numbers in our commercial book statewide, it came out to about 18.5% of total spend. You needed that to get to the 10%. The other savings that comes from this, and we used Dave Vaccine to do the pricing on this, the other savings that comes, of course, is in Tier 1. If you can get those people into better control, and you can reduce ED visits and hospital days, that's a big Tier 1 savings. But actually, in the pricing, Dave did not estimate that there would be any savings there. It all depends on how much medical management any plan has in a given market, right? So our plan, we have a ton of disease management going on right now. We have predictive software going on right now. We risk stratify everybody in our plan every month, and we have 50 to 60 nurses who all day long make outbound calls to people with chronic to keep them in control. We do that. So for us, that Tier 1 might have produced some savings, but not a lot. Other plans haven't made that investment, so he was a little nervous. But these services had to be large enough to get to a meaningful spend to get the 10% premium reduction. And interestingly, this was not hard for people to agree to. The 5 medical directors, Providence, Regents, Kaiser, ODS Health Plan, Pacific Source Health Plan, HealthNet, a couple others, they all agreed, yeah, this is the right stuff. And it was important that we use nationally recognized preference supply sensitive care. Interestingly, when I presented this product a couple years ago, a year and a half ago at a meeting, David Wenberg was there, the son of John. He didn't think we went far enough. I said, well, that's a nice start in Tier 3. I said, well, we're just trying to get a start, David, you know. So, but he thought we'd go farther. Now, if you look at this plan design, then, this is kind of what it means. If you have a $6,000 charge, the charge, this is for a tier 3 service in our product versus a standard product, you can see that the allowed amount, if everybody gets a discount, is the same. Deductible is twice the size on the right-hand side of that slide. And of course, coinsurance is a bit higher. And you can see that the out-of-pocket difference for a Tier 3 service at a $6,000 charge, $5,280 allowable, is a little more. And that's kind of how it plays out. Now, if you go to the next slide, pricing this design, we used, there were health plan actuaries in the room, but we had an outside person do this work, Dave Axing. I think most of you know Dave. He's now in Southern Cal, he's a dear friend. And he liked this design a lot, by the way. He thought it made a lot of sense. We used the Oregon Commercial Group experience in our health plan as a reference point. And we used a Providence point of service plan mid-2008 to do the comparison between that product and the new product to find the 10% reduction. You got to start somewhere, right? And we started with one of our standard plans. Now, what's interesting about this observation when we did the analysis is that in Tier 3, a third of the expenses are inpatient and 2/3 of them are outpatient. It's estimated, based on our claims experience going back 3 years, that 12% of the population will experience a Tier 3 service in any given year. So it's not a lot of people, but it's a lot of people who use a lot. It's people who use a lot of healthcare. Now, 90% of that 12% will experience Tier 3 in the emergency room. So if you have the chutzpah, for lack of a better term, to do this on ED services, on the theory that we estimate that 50 to 60% of ED services are primary care services. Actually, 20% of those should stay at home, right? If you have the energy to do this and you put it on ED services, you get a pretty big spend reduction. Now, here's where the actuarial work came in. The actuary who did the work, Dave Axine, said, I can't guarantee that the trend line on this product will be different than the trend line on your reference product because of something called trend leveraging, which basically means that as the cost of services go up in Tier 3 and the deductibles and coinsurance stay the same, you lose some of the effect of trend. Now, we're going to measure that as soon as we get enough people to buy this product, and we'll talk about that in a minute. Intuitively, it kind of feels like, God, this should trend at a lower rate. But Dave was not willing to go there. So there may be that this just brings your costs down 10%, and trend doesn't necessarily mitigate. But we shall see on that. We shall see. Now, the advantages of this design were that for those of us in this business, we thought it was pretty rational, made a lot of sense to us. And it encourages dialogue around more effective treatment of very suspect health services. It's a little more laser-like than just putting a big deductible in the way. If we wanted to use a front-end deductible, we would have had to go from $2,000 to $3,000. And finally, we think it engages employers, employees, and providers in the kind of dialogue that we need around what works in healthcare and what doesn't. And it requires people to pay more for things that have less clinical value at the population